I tend to be pretty rigorous about the information that I put out there. And guess who said this? Choosing wisely. First of all, Choosing Wisely is a program to help patients understand what's appropriate and what's not. Who developed it? Well, the key group is the ACC. Who's the ACC? The American College of Cardiology. In other words, the guys that everybody respects in terms of the final authorities in cardiology. Why did they do the Choosing Wisely program? Because they knew that patients were getting way too many tests from their docs. Well, why didn't they tell their docs? They've told the docs, here, calm down. Don't be doing all of these studies in these different areas. And they specified the places where just way too many were being done inappropriately. Why didn't they just tell the docs and let that be? Because they knew that the docs were not listening, a huge portion of them, and patients needed to hear it too. So this is a program developed for patients to say, buyer beware. If your doc wants to do one of these, you really should question this. What are some of the examples that the American College of Cardiology has said in terms of overuse of stress cardiac imaging or non-invasive imaging on these patients? Number one, in the initial evaluation of patients without cardiac symptoms, unless there are some high-risk markers. Again, it's like my 25-year-old basketball player who started getting nuclear stress tests in his 20s. Number two, as part of a routine follow-up in asymptomatic patients. Follow-up for what? Well, follow-up for a whole bunch of stuff. Once you've had your first cardiac stress test, your first nuclear stress test, then it's pretty easy to say, maybe we ought to just check that again. Well, that one statement leads to $10,000 to $20,000 worth of costs, income for the doctor, the clinic, the hospital, and a very challenging day for the patient at minimum. Number three, as preoperative assessment of patients scheduled to a low-risk non-cardiac surgery. So this thing about preoperative assessment, that is such a conundrum, such a problem within the medical areas. If somebody has a, quote, history of heart disease, then surgically, the hospital, the clinic, the surgeon all want to get, quote, cardiac clearance. Well, what is cardiac clearance? Is that saying that somebody like me with relatively benign atrial fib, somebody like me, I'm sure I would get a major workup, including nuclear stress tests. Would it help clear me for surgery? No. Would it make a lot of money? Yeah. Would it help me in terms of me feeling better? Unfortunately, that's where one of the problems is. There's a major disconnect in information on the patient side versus the doctor's side. Number four, avoid echocardiography. That's echo. That's often called sonography of the heart. It's a routine follow-up for mild asymptomatic native valve disease in adults with no change in signs or symptoms. I've got a whole lot of family members with a mitral valve prolapse. It's totally asymptomatic. And yes, if they wanted to, they could go to cardiologists all the time, anywhere, and the cardiologist would say, well, let's just get an echo. Well, that's sort of like saying, well, let's just get a nuclear stress test. Let's just get this test. Let's just get a CT. Again, you see where this starts to go. Avoid routine EKG or ECG screening as part of a low-risk surgical pre-op evaluation for asymptomatic patients. Again, some hospitals used to do a chest x-ray on everybody that came into the hospital and an EKG on everybody that came into the hospital until somebody said, we're not getting anything out of that. Why are we doing that? And guess what? Thousands of people asked that question. In fact, as a new doc, I saw that, had multiple conversations with multiple docs, and we'd all say, yep, we're not getting anything out of that. We really should have stopped that long ago. But who's going to make that stop? Who's going to make that choice? And so things just perpetuate. They continue and they continue.